said the following: "The art of surgery is incomparable in the beauty of its medium, the supreme mastery required for its perfect accomplishment, and in the issues of life, suffering, and death, which it so powerfully controls. If a man's service to humanity are the standard by which we measure his value, then Lister may be counted as perhaps the greatest man the world has ever produced, for he has been the means of abolishing or assuaging the sufferings of men and women to a degree which is quite incalculable. And as I said of him years ago, he has been the means of saving more lives than all the wars of all the ages have thrown away." So humanity, or humanism, and surgery have always been connected. And so today I think it's nice with this very distinguished panel to talk about the reasons why it's so important. And taking part in this panel are the following: Jacek Mostwin, who is professor of urology at Johns Hopkins School of Medicine; Héctor Guadalajara, head of surgery at Fundación Jiménez Diaz in Madrid; Ourania Varsou, lecturer in anatomy at the University of Glasgow, where indeed Joseph Lister held the post of professor of surgery; and of course, Adrián López, fourth-year medical student at Pompeu Fabra; and last but not least, Pelayo Aguilera, second-year medical student at Pompeu Fabra. So welcome, and thanks very much for taking part. The roundtable, we will keep very close to the times because it's important, will be divided basically into three sections. The first, Adrián and Pelayo will have mini interviews with Jacek and Héctor, and then there will be the main discussion section, and then a question and answer section. So if you have questions, you can send them in via the chat, and we can begin to see the questions for the end of the session. So I hand over to Adrián and Pelayo.
Thank you very much.
Thank you, Jonathan. May I start, Pelayo?
Sure.
I would like to ask Dr. Guadalajara. Well, before I ask my question, I would like to briefly share my first experience in surgery with all of you. The first time I got into an operating room was in my first year of medical school in one of the minor surgery workshops that we do in the Gimbernat Surgical Society. And I was with Dr. Marta Pascual, who is one of the surgeons in our hospital, and who very kindly taught me how to scrub in and even showed me some steps of the surgery, letting me help her in some simple moves. I remember going home that day really, really happy. And I probably didn't fully understand the whole procedure as it was just my first year, but I got the feeling that that thing that I was doing was extremely stimulating for me. And from that day on, I have felt this fascination for surgery every day. And I reckon that is the mission of a good mentor, like making the student so interested that he's going to remember that day for the rest of his life. I don't think Dr. Pascual remembers that day, but I will definitely always remember that day and remember her. So after this, I would like to ask Dr. Guadalajara, Héctor, if you had a similar experience with a teacher when you were a student, and if so, did it encourage you to choose surgery as your specialty?
That's exactly my case as well. I suppose this happened in almost all of us. You have the right person in the right moment that put the seed of the love of surgery, and it grows. In my case, it was Ignacio Landa. He is not working right now, but he was a great surgeon, and not only make me feel the love of surgery, but also the research in surgery. Sadly, our ways after that split up, but the seed of surgery growed on me, and I now the surgeon I am today, and I like very much, and I want to share these seats with all of the students that comes around me, and I want to make surgery great again, because I heard from my professors and my mentors that it was highly demanded specialty years ago, but now it has changed. And I think initiatives like this will help to change this.
Thank you very much for your answer.
Okay, perfect. So now I am gonna ask Professor Mostwin a similar question, and maybe many people have already asked you this, but for sure this will be really useful to guide us. And that is, how did you end up in surgery? Specifically in your case, in the field of urology, was there a person, a moment, a book that made you choose this career path? And also another question that is related, somehow related to this, would be if we went back in time, could you choose again to be a surgeon? That's my question.
Pelayo, thank you very much for inviting me and for asking the question. And I think Adrian's initial comments about being exposed to a person who took them into the community of medicine and actually showed them and allowed them to participate physically is very important. I had some of those experiences earlier as well. And there's no question but that the people you meet will greatly influence your choices. But it's complicated because I think you already have some internal sense of what you want to do, but it's not clear to you yet when you're as a student. You're looking for manifestations, expressions of what you're interested in as practiced by other people. You will look at all sorts of different people to see. When I first went to medical school, I thought I would become a psychiatrist because I was interested in the life of the mind and the spirit. And I'd never really been exposed to the life of the body in quite the way that I was when I was a student. So the seeing of people in beds in hospitals undergoing surgery, various stages of illness, really intrigued me because this was a whole theater of the world that I had not had much exposure to. And the more I saw, the more I started to move away from the pure life of the mind to the life of medicine, its complexity, its richness. And very quickly, I became intrigued by surgery, but I never thought that I had the necessary skills to be able to participate. Also, I think surgery was introduced as a less academic kind of field than internal medicine and other fields, particularly for someone who was interested in research. So it took a while to understand that that was not true, and that surgery was just as academic and just as scholarly as other fields, and you can find all the different kinds of research that you want within surgery. But the main thing that I found with respect to your particular question, the main thing I found, first of all, was a real depth of contact with another person. And that depth continued and continued and continued. And somehow I could never really get tired of that depth. It kept me going for many, many years. Regarding my initial choices, they were unquestionably directed by the people that I had met. So part of my original experience was as a patient, as a first-year medical student, when I required knee surgery and had a complicated problem that required not only a subtle diagnosis, but a very intelligent approach. And I was fortunate to finally find such a surgeon who did the operation. And I learned firsthand what it means to be a surgical patient. I learned what it means to have trust or lack of trust in another surgeon and how that's communicated, as many of you will through your own personal experiences or with your family. And then I think initially I was going to do general surgery, but I found as time went on that I needed something more specialized because all areas of surgery were becoming specialized. And I had in mind, in particular, I was intrigued by urology, although I didn't really understand what it was about. When we had lectures on the retroperitoneum, this was some mystery realm I had no concept of. We at that time, other than anatomy and the anatomy of the pelvis, which to me was as complicated as the brain, the layers of fascia, the structures, the complexity of arrangement of things, very mysterious. But there was in particular, a urologist who had been trained at Hopkins and then was at the university where I was, across town at the University of Maryland. That was Edward Campbell, we called Med. And what I remember about Ned was that he was, first of all, a gentleman. And he treated his patients with respect and care, and he was there very often. And you could see him at the bedside, and you could see his level of concern. And the other thing that struck me was how kind he was towards the rest of us. So that kindness and that feeling of being just a senior colleague stuck with me for a long time. So when I went to the University of Michigan to start in general surgery and experienced for the first time the challenges and difficulties of a very serious surgical program and surgeons who are really up to their neck in serious work, I began to see the varieties of different kinds of people. And at that point, I remembered my experiences with Ned as a medical student, and I started looking into this field more. And then it's a cultural thing, a tribal thing. You see who you get along with in your various specialties. Do you like the sort of precision and meticulous work of the plastic surgeons? Do you like the rough and tumble work of orthopedic surgery? Do you like the big, intense work of abdominal and cavitary surgery? And little by little, you have to find your way. There is no obvious answer. And I think it's wrong to suggest to a student that they fit into a certain category. The student should take from each category what they find is most applicable to themselves. So it is an intuitive thing. There's no question that role models play a very important role. At the same time, there is wisdom in sort of the general stories that you hear around school, but that wisdom has its limits. And that limit should be your own intuition, which should serve as your guide. Now, the future of surgery, as Héctor was saying, I think is changing. When I became, I graduated from medical school in 1975, and at that time, large cavitary surgery was still sort of the dominant theme of surgery. Even in critical care, CT scanning, MRI, intensive care work, all of that was just emerging. Anesthesia was getting more and more refined. And so I think more can be done surgically now than could be done, say, 30, 40 years ago. At the same time, the focus of surgery is changing, thanks in part to Paul Farmer's work in the program on global surgery at Harvard and the Lancet program in global surgery. There's now an awareness of just how much surgery is needed throughout the world. And the challenges are how to scale up what surgeons have usually done on a very intimate one-to-one level with one person, how to scale that up to the broader world and think of surgery as a public health issue and not just a personal face-to-face issue. So these are issues for the future that I think are very intriguing. There's a great deal of involvement of technology, robotic surgery, but I don't think that, and some people will go into surgery primarily because of their fascination with the technology, and that's fine. I think there's a long period of apprenticeship during which you have to learn the details of the craft, but sooner or later you emerge from that with experience, and then you start to see the importance of surgery for humanity, if you will. And this is where the humanism of surgery comes, where now that you are a skilled person, you can start to deploy those skills in a variety of ways. On the individual level, you can deploy those skills with the way you connect with another person, the level of understanding that you have of the person as a complete human being, not just a mind, but a mind and a body, because the mind and the body are realistically one. We just talk about them in different ways. But you have to communicate this, and once you understand, you can communicate this. And then there are the broader issues of public health. So I'll stop with that and just say that this is a growing field that's going to be more important rather than less important as time goes on. And experts in the field are going to be really necessary.
Thank you really very much for all these comments. They were really interesting. I was really impacted by the view that you gave us about the future of surgery. And I pass on the mic to Jonathan to continue with the conference.
Thanks very much, Pelayo. Thanks very much, Adrián. Thanks very much, Héctor and Jacek. Theatre of the medical world. I love that, especially as in English, we talk about the operating theatre, but it brought to mind Shakespeare in All the World's a Stage, the famous monologue in All's Well That Ends Well. However, let's move on, and don't forget that with us today are distinguished surgeons, but we also have a very distinguished anatomist. So my first question is, well, starting with Ourania. Ourania, let's kind of move into the anatomical stage, as it were, or theatre, as it were. Where does the cadaver stop and the person begin?
Thank you, Jonathan. First of all, thank you, everyone. And thank you, Professor Pera, Pelayo and Adrián, for the kind invitation. And thank you, Jonathan, for that question. So it's a very interesting question. Where does the cadaver stop and where does the human or the donor start? I think to be able to properly answer that, it's important. I always go back and I try to understand what the actual word means, the etymology of the word or the meaning or the origin of the word. And I think it's important for us to appreciate that the donor is somebody who gives, freely gives. So that's basically the meaning of the word, is to give. And cadaver is to fall. It's something that has fallen, and it represents the bodies of the deceased that have fallen. So even by looking at the etymology of the word, we can understand that they take part in a certain order. First is to give, and then is to fall. In anatomy in general, and when we look back at Latin, the words are very crude and they just represent exactly the act of what happens. There is no, it's just the intrinsic value of the word that we see here. We don't see any associated values, we don't see the socio-political, we don't see the religious or the cultural connotations that we assign to a word. And that is quite important in anatomy, because the cadaver nowadays, if you ask people, if you ask like myself or other people or students, the first thing that comes to mind maybe is not just the corpse, but it's also a dehumanized version of the person who once was that cadaver. So we go into more into the scientific, the hard scientific aspect of the word, which is not what this word is about. So I always like starting with the history and explaining that active process that was that interlinked process between somebody who gave their body and then was fallen to be examined, because that's how I feel anatomists have used these two words. First of all, the donor, and then the cadaver. But as time has passed, the cadaver, and I'm going to speak from the UK perspective of anatomical examination, because different things have happened in other continental countries, in the continent and in other countries. But in the UK, the cadaver has had, because of anatomical examination and the historical aspects of anatomical examination in this country, it has had at points a negative connotation to it. The word doesn't have on its own a negative connotation. It's what we, the humans, over the passage of time, we have assigned to that word. So when we had the body snatchers, for example, in Scotland, there was a fear of what was going to happen to the cadaver. So straight away, when somebody had fallen and had passed away, there was a fear of what to do with the cadaver and how to protect the corpse from the body snatchers and anatomical examination. So over the time, the cadaver has been dehumanized and has been stripped of what it was supposed to mean. And the same applies not just to the cadaver, but to tissue. And I'm going to touch a very, very sensitive topic, which is the loss of a baby. The loss of a fetus before 24 weeks, and I'm going to speak about the UK here, it's called tissue. But after the 24 weeks, called fetus, and some people still call it a tissue. To some people, tissue is very dehumanized. Is not. It doesn't represent what that life is about. And the same applies to our body. If we were to, let's say, have an amputee and remove their arm, that is a limb, but the limb again has a dehumanized connotation to it. And I believe that this has happened, as I have said, over time. It is not something that the actual word was supposed to mean. It is what we, over the time, have assigned to the word. So where do we draw the line between the donor and the cadaver, or the tissue, or the limb, or a region of the human body? I don't think there is a line. It's the line we have created. I think the donor is somebody who has freely and voluntarily has taken a very important decision to donate their body following informed consent while they're still alive. And then once they pass, their body can be used with their consent, of course, for anatomical examination. So the line is a line we have imposed, and we have, in a way, taken it to the next level, which is the which I think humans like putting things in boxes to look nice and neat. So we have the donor and then we have the cadaver. I think that's a very, very arbitrary distinction. A lot of colleagues are doing work in that area. Myself, I haven't done work on it, but I have looked at other colleagues' work. It's fascinating. There is a move at the moment when we have the cadavers in the anatomical, in the dissecting rooms, to acknowledge who the donor was, to look at their past medical history, to look at their social history, and try to identify with that person. So when we do the anatomical examination, we appreciate who the person was, what their life was about, what their social history was about, and try and link the findings we find in the dissecting room with their social history. For example, if somebody has stigmata of being a smoker, so what do we find? How does this link? Who was that person? But other colleagues have also done work into taking to the next level and treating the cadaver as the teacher who is going to tell us about the human body and start us into the journey of exploring the different anatomical structures. And in some countries, students pay respect to the teacher before they start an anatomical examination. And I feel that as time passes more, there has been, I think that the humanization anatomy has started roughly in the 90s and is still continuing, but is fading as time passes, because we start appreciating that the dissecting room is where students start forming their professional identity. It is not just about exploring the anatomy. It is about the ethics of anatomy. It is about appreciating the legalities of being exposed to a cadaver, and of course, respecting the person who is in front of you. And other colleagues also have looked into the donor and the cadaver being the first silent patient. And there is some literature into it, treating the cadaver as your first silent patient, and silent because they can't say anything back, but because they will teach you a lot. So to summarize, because I can talk forever, I don't think there is a line. I think it's a line as the humans, our socio-political, our cultural, religious environment has created a line, and it's for us to break that line and create a continuum.
Fascinating, Ourania, fascinating. And talking about the importance of words, and maybe the words are losing their meanings and losing their validity. Humans pervert and change the meaning of words quite easily. I move on to Héctor. Héctor, would you like to answer that question? Héctor?
Sorry.
Oh, yeah.
I'm not an expert on this, and I fully subscribe what Ourania said. And her reflections have given me some light to this. I totally agree. I like the idea of seeing a cadaver as a teacher, and I remember since the very beginning I was very, very reluctant to make dissections in cadaver. Even now, when I have to practice some kind of robotic technique, for example, that was the last time I had to deal with cadavers. I feel very uncomfortable there. But I think that trying to see it like a teacher, it will help me to deal with this. Thank you, Ourania, for your comment.
Thank you, Héctor. Jacek, do you feel as uncomfortable as Héctor, or do you have a different feeling?
Well, I perhaps a little bit different. I haven't been in a dissecting room for a long time. There was, of course, my extensive anatomical work as a first-year student. And then after I finished my residency, I probably spent an additional 5 years going back and forth to the anatomy board, which is the place of donated bodies across town. I was working at Hopkins. The anatomy board was at Maryland, run by a former funeral director, very interesting man, Ron Wade, who then became an expert in mummification and Egyptology. No, it's a very fascinating man. Anyway, they had worked on different forms of plastination and ways of embalming, etc. But my interest was to master pelvic anatomy in men and women, and this gave me the chance to do this on fresh, not embalmed cadavers. I learned many things. The first experience, to go back to my being a first-year medical student, I am the kind of person that Ourania was talking about, looking at this first experience with the dissection. And I remember distinctly after 5 months or however long it was of this extensive dissection of individual bits and pieces, we finally cut through the skin of the back to go to the metal of the table. The metal of the cutting scalpel went onto the metal of the table. And all of a sudden I found myself asking this question, well, where was the person? And it seems as though that is a question that then characterized my search in medicine for the rest of my life, reconciling the person with the body. In a way, when I went to the morgue after my residency, I used to joke about it as being life in the morgue. That was my expression, because it was actually a very lively place. I got to know the people who worked there very well. And then also what they did, and this is similar to perhaps maybe lesser known, medical students today will have kind of memorial services for their donated bodies or cadavers that end up being cremated and returned to families sometimes, but not always. And I learned at the anatomy board that most of the bodies had been donated, and that most of the remains, they were very cautious about this. When we were done with dissections, we were asked to return them specifically to certain containers, etc. They were always considered as part of a former person. They would then be cremated. 2/3 of them were returned, the ashes were returned to the families, and the rest were then buried in a communal grave at one of the old state psychiatric hospitals outside the city. And this took place once a year, and there was a memorial service, and it was attended by professed religious and ordained ministers of various churches and denominations. So there were prayers, there was a sacred reading, medical students would speak, former family members would speak, and there was this atmosphere of solemnity and reverence. And it was quite touching. And I felt that I'd come full circle, at least with the first chapter of this, where is the person? I had some answer, but then the next chapter is what we're talking about today. Where's the living person in the living body? So I'll stop at that.
Thank you very much, Jacek. It's very interesting, where is the person? Because I remember very well one of the comments you made in Moscow, which seems like about 10 years ago, but it was really only 2 years ago, when you said the important thing is to find or to look for the person in the patient. And I remember that, and this is one of your quotations, but I think it's actually from your wife, I think, to look for the person in the patient.
She's able to find the person in the child, because she works with children. So that was, yes.
Child. Yeah, it's a beautiful quotation. We just had, before we move on, I'm going to ask Adrián and Pelayo, we just had a very good recommendation from Natalia Mesa, who recommends the book, All That Remains, A Life in Death by Sue Black. And she says it's an amazing book on the subject. I will write it and tell Adrián and Pelayo later. I have a question for you, Adrián and Pelayo, one of you or both of you. I think in Pompey Fabra, I think, and you will correct me, but you don't use cadavers in Pompey Fabra. So can you give us the perspective of the anatomy, learning anatomy without the cadaver? Pelayo or Adrián?
You can go. Yeah. You go?
You can go.
I mean,
either of you, no problems.
Yeah, it's kind of I was going to say weird, but it's different. It's a different way of learning that we have here in our university, because there were some technical problems with bringing cadavers to our faculty, but we use plastic models, and we have other resources that are also really useful. We also use new technologies as different applications that you can see in 3D the different parts of the body, and you can take out parts and also put in different organs or different arteries, veins, whatever. And yeah, it's maybe we have an experience what many medical students have, and that is this first encounter with the person / cadaver. They don't want to make that difference, but but still, I think that we have a really good learning outcome to compensate this lack of cadavers. We go to see surgeries, and we see the actual life structures in patients, and which is more accurate than the one that you would see in a cadaver.
Thank you very much.
It was indeed the first generation in which the first year we did the dissection room, and the second one we did all these models that Pelayo has taught. And I can assure that the theoretical anatomy is the same, or even you learn it better from the programs that Pelayo has said. So it's a different way. You don't get to see the dissection room and the feelings that you get there, but the anatomical learning, I think it's the same or even better.
Interesting. I think we would have a lot more, could have a lot more discussion about this topic, and especially maybe Ourania to come back on the idea of learning anatomy without the cadaver, without the silent patient.
One thing I will say, I'm not gonna elaborate too much, is whenever you look at an illustration, it doesn't matter whether you have a real cadaver in front of you or an illustration or a virtual cadaver. That illustration or that virtual cadaver came from a human, came from a person. So the distinction is still the same. So the thoughts are still the same. So it does not change from the topic at all, whether it's a virtual cadaver or a virtual illustration.
Thanks very much, Ourania. We're trying to kind of divide this in also into the past, the present, and the future. So the second question we'll talk about experiences of surgeons, and there's a quotation by Henry Marsh that Jacek and Ourania will tell me that he's quoting from somebody else, but he says, every surgeon carries within himself a small cemetery, where from time to time he goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures. Jacek, I'll ask you first. How do you cope? Is this true? And if it's true, how do you cope with the suffering of the patient?
Well, there's the suffering of the patient that you have caused, and there's the suffering of the patient that the situation and the illness have caused. So I think that when Larisha made this quote, this was at the beginning of the 20th century, and surgery was very different. There were no antibiotics and there was no blood banking. And so cavitary surgery was fraught with difficulty. And he grew up at a time when even vascular surgery was in its infancy. His colleague, Alexis Carrel, introduced the methods of vascular anatomy that then, vascular anastomosis, that then Lariche made very popular. But there's no question that all of us have experienced complications, and you rack your brain on these things. How did it happen, etc. But above all, and I think in our preliminary conversations, Héctor and I both agreed on this, that there is something visceral that connects you with the patient. And when something goes wrong and you think it might have been your fault, or even if it wasn't your fault and a complication occurred in surgery, you can feel this physically. And I think it shows the extent of involvement that surgeons have with their patients. They can vary in this regard. I know medical students will come up to me still and ask, how do I maintain an objective distance from the patient? Because they can feel this pull of the other person tugging them in to the situation. And my answer is that you simply can't. You cannot create an objective distance between yourself and the patient. You are involved whether you want to be or not. And that's part of what medicine is involvement in the life of other people. So there is regret, there is remorse, but there is also reality. And no matter how much work you do, sooner or later, things will go wrong. You may blame yourself. It may or may not be your fault, but you experience this and you see the consequences. So you begin to realize that the effects of surgery can be permanent, and you can really hurt people with an operation as well as help them. You can hurt them in other ways as well. But so there's a lot at stake. There's a lot of responsibility, and you have to keep this in mind. As a result, when surgeons get older, they tend to become a little more conservative because, as my former chairman, Pat Walsh, used to say, good results are based on experience, and experience is based on bad results.
I like that. I like that. Do you, there's a very nice quotation, I think it's from John Hunter, I think, who says that the good surgeon knows not to operate. Is that, do you get, would you say that that was important, knowing when not to operate?
It depends on who the accountant is looking over your shoulders.
It depends on the, yeah.
You know, I think an ethical, humane, and a responsible surgeon will do that. And again, with experience and time comes another adage that we've adopted, which is only do what's necessary. So don't take unnecessary chances. Sometimes you have to take risks and chances because courage is an essential quality of surgery. You must be willing to do what needs to be done, but at the same time, it should not be foolhardy. There has to be a sense of serious responsibility based on lots of experience and judgment and consultation with others, but basically just do what is necessary.
Just do what is necessary. Thank you so much, Jacek. Héctor, what about you? Does it get easier as you get more veteran? I was going to say older. I was going to say more distinguished, more veteran, more experienced, to cope with the suffering of patients? Héctor.
That's what I used to think, or I wanted to think, that the experience and the age would me cope better with this, but sadly it doesn't happen. It gets even worse. So this is something that students willing to do surgery may think or make reflections about before choosing this career. And the only way that they can interact with the suffering of patients is being with them. That's the reason why I consider so important the clinical practice. And I leave in a second place the simulation and other kind of learning, because the suffering, the only way that you can interact with it is being beside the patient and the surgeon that is suffering with them. It is easy to say that you suffer and you physically feel it, but probably not many students know what I mean saying this. And I'm going to make a picture that probably they will understand much better. Consider that it is not the case that is your fault. That is the disease who is causing the suffering to this patient. But when you make something that has a bad outcome, it may compare with accident that happened while you are driving. For example, someone crossed the zebra pass without looking at or even running, and you don't see him, and you crash on him, and you hurt that person. Maybe it's not your fault, but you have you hurt him with your car, and this is somehow the feeling that a surgeon has when this happens. And that's the reason I think this question is so important, and I think it was a great idea to raise it here today.
Thank you so much, Héctor. Thank you so much for that very graphic image. Ourania, I know this is probably a bit out of your field, but do you have any comments here?
This is a bit out of my league to comment. So, but I agree with what has been said, and I'm going to stay neutral because not my expertise.
Okay, I'm wondering whether Adrián or Pelayo have anything to comment about this as well, because it's a bit out of your league as well, or your field as well. So
yes,
far,
we haven't already, we haven't yet experienced this kind of pain, but for sure it's something that we should train to cope with it, and hopefully we will learn it throughout medical school, so that when we actually encounter these difficult situations, because 100% we'll probably encounter some these difficulties, so that we are prepared and we can tackle them.
I would just, if it's possible, I would just want to add, we talked about Henry Marsh, but he also says something in his book, which is, and it's related with what Dr. Mostwin was talking, and it takes 3 months to learn how to operate, 3 years to learn when to operate, and 30 years to learn when not to operate. And it's related with the title of his first book, which is Do No Harm, in Spanish, Ante Todo No Hagas Daño. It's the primum non nocere that was 100 years ago by Hippocrates. And nowadays, I think we still have a lot of algorithms when doctors go to Congress to stay updated. We medical students have to learn long list of indications of algorithms, and still the main mortality in many developed countries is iatrogeny. So I think it's very important also for new generations to know when not to operate or when not to order a test that can harm the patient.
I would completely agree with you, Adrián, when not to order a test, when not to operate, when neither are necessary. We have time to move on to the future, because Adrián and Pelayo represent the future. I'm not saying that Héctor and Jacek and Ourania don't represent the future. Of course they do, but Adrián and Pelayo will be the surgeons of the future, we hope. I have the next question, and I will begin with Héctor. What about the future of surgery, Héctor? Is there room for humanism, or will it be a question of artificial intelligence, robotics, with the surgeon a mere technician? We can't hear.
Sorry. You already know my opinion about this. We have already talked about it. I think the future of surgery is purely a humanism, because I'm pretty sure that the mission of surgeon will be care of human people from a human point of view, and we have to defend this position. Why I say this? Because I think that in a near future, well, not near, but in not far away future, procedures will be done by robots, and many decisions will be taken by artificial intelligence. But someone must interact and care, or give love, and take their hands and assessorate and give counsel, and that will be the mission of the surgeons of the next generation. That's how I see the future of my profession. Robots will do the work for us, but there is still room for humanism, and that will be our mission.
I think it's great that the surgeons will be teaching the physicians about humanism and the humanities in medicine. I think that's beautiful, kind of turning everything around, or maybe. And I think it's a beautiful vision you have, Héctor. I'm wondering whether Jacek, what would you say, Jacek? What's your opinion?
Well, I'll start with something humorous, because whenever I hear about the future, I always think of this comment by Yogi Berra. I don't know if the audience knows who Yogi Berra was. He was sort of this homespun philosopher who started out as a catcher, which is a particular role in American baseball, and then became manager of I don't even remember if it's the Mets or the Yankees anymore. I've lost my interest in those things. But Yogi Berra developed a sort of a reputation as a homespun philosopher, and one of his great expressions was, "The future is not what it used to be." So I would say that we can't really predict. We can't predict what's going to happen. Who would have predicted the COVID epidemic 2 years ago? Who would have predicted Ebola? Who would have predicted the warming changes that have been taking place around the climate? These are things that you cannot tell. This is what our State Department calls being overtaken by events. And as a result, there are many forces at work that will shape the future of surgery. But I agree with all of you here that the future of surgery the structure of it will be created by people, not machines. It'll be people using machines in new and creative ways. But the implementation and the sort of human side of it has to be shaped by people. We do have the risk of what we call the dog wagging the tail, which is machinery and technology determining what can and should be done. And it's inevitable that there's going to be a powerful force here because there's a lot of business and industrial interest in this, but none of this can go forward without the cooperation and leadership of surgeons. And sometimes they do lead this technological development. Sometimes they merely comply with the technological development because it's easier than other things and they don't want to be left behind. People are afraid of no longer being part of the new. So a broad understanding of the history of surgery, a deep understanding of the nature of the diseases and what people need and how they go through operations, because no machine will tell you this. The machines are going to be all dependent upon outcome studies, and outcome studies are very difficult to do because subjective issues in outcome studies are very murky and they tend to be left behind in favor of measurable outcomes. That's what's characterized most medical studies in the past, especially surgical outcomes. The focus has not been on the experience of the patient, something that Roy Porter, who was formerly the head of the Wellcome Institute, wrote about many years ago, about doing medical history from the ground up, from the patient's side. There are only two people who understand this. First of all, the patient, him or herself, and secondly, an intelligent enough physician who understands what it means to do an operation and what an operation involves, and then to be able to interpret and share the dialogue with the patient. That kind of dialogue is essential for the future to create the best kind of surgical environment we have. And then bring in the machines, bring in the technology, bring in the AI. This is like saying we can use now an airplane to fly from New York to London instead of rowing a boat. And of course, this is a great progress, but there has to be a human side to it. Why are we doing it? What is the purpose of this? What are we hoping for? And are we going to watch a good movie on the flight? So those are all things that make these experiences human. And that kind of humanization is what this program is about. And it's, I think, what many of us share. We want to see this kind of humanized medicine and specifically humanized surgery.
Thank you so much, Jacek. I see that you're strapped in your car. So this is probably good, a good message for me to begin to wrap up. And we do have a little bit of time now for questions and answers. So if anybody has any questions from the audience, we'd be delighted to hear your questions. We have maybe 3 minutes for questions and answers. Anybody, you can write the questions in the chat, or Adrián and Pelayo will give you permission, give you a co-hosting so you can ask a question, which I always think is nicer. Students, this is your great opportunity to ask a question now at the end of what I know has been a very successful scalpel symposium. I also talking about surgery and yes, Luthea, please. Luthea, do you have co-hosting? If you.
Hello?
Yeah, hi.
Okay, sorry, yeah, I was having some trouble. Thank you so much for the it's not a talk, how do you say it? Well, it was, yeah, thank you very much. It was very interesting. I have to say, it's the first kind of talk that I assist of humanism, so I'm not really into this field. But
Luthea, before you begin, because it would be very nice to put you into a context, can you tell us who you are, if you're a student, if you're a doctor?
Oh, yeah. Hi, I'm Lucia. I'm a medical student. I'm in the ACUG also, and I'm in my 4th year.
Fantastic.
Also, I'm with Adrián.
Fabulous.
Yeah, thank you. No, I was something that really made me think is I think Jacek, is that how you say it? I'm sorry.
Yes, that's fine.
I was talking about the future, and this is something that I've been thinking about lately, about how we think that technology is going to be more and more important over the years, and something that it's not bothering, but it's something that I'm afraid of, is that with the climate change, we won't be able to have so much technology, and the doctor, as a human, is gonna take more importance in the surgery than the machines. This is a thought that I've been having, but I don't know if it's something that makes sense or not.
Thanks very much, Lucia. I would say the doctor as a humanist. Jacek.
Well, among the many hats that doctors have to wear, being a humanist is one of them, and no specialty has a monopoly on this. Every physician is, by title, allowed to be humanistic in their perspective. And it may sometimes get lost in surgery because of all the technology, the activity, the flurry of events, but that fundamental contact that you start out with your, if you have a cadaver dissection, and then later with your first patients and your first experiences, that is the essence of the medical life, is understanding how disease affects individual people and then how it affects populations. And after that, it's a matter of reaching into your toolkit to use what is necessary for what is called the art of medicine. And technology is going to be part of that. In what form, you're going to have to determine, and you will not be allowed to determine that on your own. But you're going to have, the doctor is going to have an enormous voice, if they wish. They have to find that voice and they have to cultivate it, but the possibilities are there. So if you're interested, start searching now, see what people are doing about the world at large. By the time you become a surgeon, if that's what you choose, the world will have already changed a great deal and will continue to change throughout your life. So if you want to have a role in it, you certainly can.
Thank you. Thank you. So yeah, I might start.
Thank you very much, Lucia and Jacek. Lucia, I don't want to plug anything, but you can always get involved in the Doctor as a Humanist as well. However, time is running out, and I'm just going to ask each member of the panel just to say one sentence to wrap up. So we'll begin with Ourania, because I feel I haven't left you to one side, Ourania, but I would love you just to wrap up with one sentence, with a soundbite, please.
Oh gosh, I'm on the spotlight. You didn't tell me that, and I haven't prepared anything. So, I'll go back to anatomy, and my sentence will be the human and the cadaver is a continuum. Do not put barriers and walls between the two.
That's beautiful. Thank you very much. Héctor?
Well, I haven't prepared it either, but I think I think, and I love to see students that show their interest in surgery, and that makes me proactive, and I like to stimulate even more them to join this amazing profession, and I highly recommend you to test it and see if you like it. Join us.
Thank you very much, Héctor. And Professor Mostwin.
I would say have faith in yourself, and believe that when the time comes, you will do the right thing.
Thank you so much. Well, it gives me great pleasure to thank all of you. It's been a superb roundtable. I've really enjoyed it. I've learned a lot from the speakers and from the questions. And I just would like to pass over now to Pelayo and Adrián, because this is the last section, the last lecture, the last presentation, roundtable of the whole symposium. So Pelayo, please. Thank you very much.
Thank you, Jonathan. Well, First of all, I would like to thank all of the speakers that have participated in today's session, in today's roundtable. It's been such an interesting talk that conversation we've had here today. And of course, we must thank Jonathan for making today's session possible, as he's been the organizer of this roundtable.
Real pleasure. Thank you.
Now, sadly, we have to put an end to what has been an outstanding week full of remarkable talks, as the one we've listened to today, and workshops. Not only we've learned the different surgical techniques and attended great lectures, but thanks to the symposiums, we've been able to feel a little bit like surgeons and have a closer view of what surgery has to offer. We would like to express our gratitude to every person that has made this second edition of the Scalpel Symposium possible. First, thanks to all the committee members who have been working so hard during the last month in order to pull ahead this project, despite all the difficult health situations that we have all encountered and we have to tackle with. Thanks to all the professors that have dedicated their times to teach the different workshops this week. And also an important mention needs to be made to every speaker who has contributed to our conference, which, well, they're having talks that have provided a different insight into medical formation that is not usually received among or during our medical degree. And the most important acknowledgement is to every single student who had decided to enroll in the Scalpel Symposium and participate in the activities we've had. It's you, the students, the real protagonists in this project. And without your interest, we couldn't have pulled all this week through. So last but not least, we must thank especially Dr. Manuel Pera, the honorary president of the Universitario Society, for his unconditional help and commitment to university teaching, and particularly for the help he has provided us organizing these events and many other activities throughout the years. Thank you all very much. And now I pass on the mic to Adrián, so because he's going to, yeah.
Yes, Dr. Pera has just gone to the OR and has texted me saying thank you to all the speakers. And I would also want to thank all the speakers who have come here, and Jonathan too for organizing the event. Thank you. Now, in order to give value to the teaching that Hospital del Mar surgeons have given to us this year, we have asked the university students to vote for the professor they consider has contributed the most to our academic and clinical training. We have to say that the survey's results have been very fragmented, and many surgeons have disputed the first position in the last moment. This not only shows that our students have been broadly satisfied by the teaching received from multiple professors, but also manifests the high quality of the surgical training we have received. Therefore, it gives me a great pleasure to announce that the Best Surgery Teacher of the Year 2021 award goes to Dr. Juan Guzmán. Unfortunately, he has not been able to be here today with us. He's working in the clinic, but we also wanted to highlight his contribution today. And well, he's indeed one of the doctors who teaches us how to suture in the Basis of Surgery course in the 4th year of medical school. Also, he works in the surgical emergency department of Hospital del Mar, and is one of the doctors who very well teaches us how to cope with different surgical emergencies. And talking about this, we would also want to announce that Dr. Guzmán has recently started a YouTube channel, you can see it here, in order to disseminate his knowledge not only to Pompeu Fabra University students, but also with students from all around the world. Here is, if I can, a short clip of one of his videos for you to virtually meet him today. Let's see if I can put it.
Personas sufren traumatismo craneoencefálico y este está asociado a una serie de eventos a tomar en cuenta en la valoración inicial, ya sea a nivel prehospitalario como hospitalario, en el servicio de triaje, en el tópico de curas o en el tópico de atención rápida, ya sea box de códigos o trauma shock. Toda esta información vamos a gestionarla en 3 grandes grupos, que son 3 grandes preguntas a considerar para rellenar la historia clínica, hacer un buen curso del paciente y darle un tratamiento oportuno. Y son si el paciente con trauma craneoencefálico perdió o no perdió la conciencia, sin o con pérdida transitoria de conciencia. El segundo grupo será valorar la lesión o lesiones asociadas. Y el tercer grupo, el contexto en el cual ocurrió este evento, ya sea una caída casual, una agresión física, un probable cuadro sincopal, un accidente laboral, un accidente de tráfico, un intento autolítico, entre otras cosas.
Okay, so we encourage everyone to subscribe and give a bunch of likes and comments to his amazing videos. And well, it's a great honor to learn from him every day, as well as the rest of the general surgery team in Hospital del Mar. We're also very thankful to all of them. And now we officially close Scalpel 2021 and eagerly wait to see you again next year in the Jim Bernat Surgical Symposium of 2022. Thank you very much.